Good evening. It's a pleasure to welcome you to today's webinar on bronchoscopic and surgical lung volume reduction. Both surgical as well as bronchoscopic lung volume reduction have their own history, and with recent head-to-head comparisons available and still ongoing in studies. This topic is really of great interest to the thoracic surgical community, and I'm happy that we have two excellent speakers today. We have Didier Schneider from Zurich. He's longstanding deputy head of the department and has a long history of being involved in lung volume reduction. And for the bronchoscopic side, we have Daniela Gompelmann. She's a professor for interventional bronchiology here in Vienna, and I'm very happy to have her as my sparring partner in volume reduction here in Vienna. And I'm looking forward to the two presentations. Didier will start, then Daniela will give the second presentation, and we will have the discussion afterwards. So if during the presentations any question come up, you can always insert them into the chat tool or the Q&A tool, and we'll discuss them after the presentations. So Didier, we're looking forward to your presentation.
Okay. Hello, everybody. I'm happy to present our data from the lung volume reduction surgery, the surgeon's view. Can you see my slides? Okay, very good. I have, no conflict of interest. Maybe Medtronic has an institutional grant for fellowships and Intuitive as proctorship. So what's new? Actually, there is nothing much new. We have seen everything already, but I hope I can give you some more insights of how we do it and what is the current status, and maybe on some difficult cases as well. So the background is that the epidemiological problem is still the same. So that COPD is a common and often disabling condition, and is the third largest cause of death worldwide. And it's one of the 10 most frequent causes of death, but it's the only one, COPD is the only one that still is increasing in the trend. So we have had a study in Switzerland from people random chosen between 18 and 60 years, and they show the prevalence for COPD for almost 10%. Yep. So lung destruction and the lung function worsening is shown here for non-smokers and for smokers. So that just want to show you that in any case, whenever you stop smoking, it's a good thing to do. So stop smoking is very important for those people and for the disease, and also to stay active. So this is a population of 3,000 patients, and you can see that the higher the activity, so the red is the very high activity and the dark is the very low activity. The higher the activity is, the better chance is the survival, which is shown here on the graph. So what we have in concert with treatments is stop smoking. As I said, we have the medication, we have rehabilitation, we have supplementation of oxygen. But what we do when we have done all of this? So then we come into the LVR domain, and LVR is recommended in national and international guidelines for COPD management. So this is the gold report of 2022, which shows that there is an evidence in lung volume reduction surgery and in bronchoscopical interventions for endobronchial valves. So the mean difference in residual volume between interventions on LVR and standard of care is shown here, and you can see that there is always in favor of lung volume reduction, any way we do it. The same is true for the FEV1 between interventions and the standard of care. So the concept of the LVR is very well known. We have the flattened diaphragm, and because of the overinflated lung, which we want to have coming back to function, and for that reason we have to reduce the volume. So when you see one of the good cases on the right side with the upper lobe predominant emphysema, then you can then we have the patient that we can treat very nicely, and this was even shown in different in different studies, and here you can see the probability of death for upper lobe predominance and low baseline exercise is crucial. So medical therapy and surgery here. So the areas for emphysema, so the surgery is a target surgery on the target zone, so we can go for different zones and different loans, which is on different lobe, which is the most the biggest difference to the valves. And but the outcome or the function or the dynamics is the same. So we will have to reduce the volume so that the diaphragm is working better. We have different kind of morphology. The markedly heterogeneous, which is the most obvious and best to treat, and then we have the intermediate heterogeneous and the homogeneous, which is the most difficult to treat. So precondition for patients that we want to treat is that they have to stop smoking at least for 3 months. Usually we had 6 months up before. They have to complete the pulmonary rehabilitation, and then they have to fit in the lung function test as shown here. CT morphology and the 6-minute walking test, there is are the other parameters we're looking for. I have also written no pulmonary hypertension. This is a relative contraindication. I will show it later on as well. So requirements for good results is a good number of cases. The interdisciplinary emphysema board with pulmonologist, thoracic surgeon, and radiologist, and a dedicated team, and very important, anesthesiologist and physiotherapist as well. And whenever possible, it's easier to collaborate with the transplant unit because then you have a fallback strategy. Standard of care for LVRs, we all know. That was the NET trial program by a dedicated team, as I said before, and the approach is bilateral non-atomic volume reduction by stapler, which is our approach usually. So that's the standard of care of our group. Bilateral VATS approach whenever possible. Bilateral careful tissue handling, that's for sure. Minimal residual space. Extubation in the OR by laryngeal mask so they don't cough. Prolonged perioperative antibiotics and postoperative monitoring on the not on the ICU but the intermediate care. Very important also early mobilization. What we always do, we give a 3-month full. We are very liberal with anticoagulation, especially if we do it on both sides and the patient is disabled. So this is the selection criteria on patients from the Zurich group shown here in comparison to the NET trial, and here you can see that those who did not good in the NET trial is because they had not looked on hypercapnia and they didn't look about the DLCO. So if DLCO is less than 20%, that means that this is a destroyed lung, and there you have to be very careful. So we have these 3 different categories. So the good ones is the symptomatic patient with marked hyperinflation. So we will talk first about this, and then I have at the end I go back to the bad and the uncertain, and we'll show you some results we have with this kind of patients. So the upper lobe predominant heterogeneous emphysema is the very good one, and those are the ones to have to profit usually most. So before we go to the OR, we have to plan what we're going to do. We have an interdisciplinary discussion for the patient selection on the emphysema board, and we already discussed which area that we're going to go for. So as I said before, we do try to go for a bilateral approach whenever possible. So it depends which target area we go for the positioning of the patient. So we have a supine position. If you have upper lobe predominant, then we don't have to turn the patient. So we do both sides in the same position. So we start with the more destructed part first. In case that we have to stop after the first side, then we have done at least the more destructed part. And when we are going for the lower lobe, or if we do only one side, we usually go in lateral decubitus position, as you see here on the right. The supine upper lobe, the trocar positioning is shown here again. So we go from the more destroyed sides to the other side, and we only go there if we have not too much air leak when we have completed the first side. Lateral decubitus position in unilateral or lower lobe target areas then is shown here, the trocar positioning. Here in the video, I will show you quickly what we do during the operation. So we look inside and we look more from the front. So this is an upper lobe predominant, and we do re-insufflation. So we try to re-insufflate to see the part that we want to resect. So it's easier if you have seen it reinflated, because if you cut the part out without you have seen how it looks like when it's reinflated, then probably either you don't take enough, or sometimes you take too much, and maybe not on the right spot. So that's what we do. We do a reinflation, and after the reinflation, we go with our instruments. When we try to evaluate and estimate what we're gonna take out. We never go too close to the hilum because of the shearing forces when we do a reinflation. We usually start around the high of the asparagus vein when we start the resection. So we come in with the stapler. We start with the stapler on the front, and then very important, this is the next very important step, we go over the top hockey stick like. So that means that we go straight behind, but we take the lung from behind and bring it to the front, so that we have like a curve. So we have the same form and the same specification of the upper lobe as it has been before. We don't cut straight down, because then you have a residual space up there and the lung is not coming up the way you want to have it. So that's what we call hockey stick shape resection. So I show you what we do, and you see now when we have done the first two cuts, we go behind and we take in front the upper lobe. We take it from back to the front, and then we come in with the stapler again, and this makes this hockey stick form at the end. So this is the last bite, and at the end you can see what we have taken out. So it's going like this and over the top. Okay. So our results, just to show you what we have done so far, when we look at our results between January 2000 and December 2023, we have done 723 LVRs on patients, and one stage bilateral was in 59% of all the cases. We have done 65 re-LVRS cases, so 9% of all, and we have transplanted patients after LVRS in about 10%. The mean age of our patients is 65 years old. Females are 47%. We have done a one-stage bilateral surgery in 55%, and the upper lobe predominant emphysema was in 217 patients. Unilateral surgery we have done in 45%, and there are different reasons why we have done it in only unilateral, because I said at the beginning that whenever possible, we aim for a bilateral operation. So it depends on emphysema distribution, on the DLCO, whether they have had any other interventions before, and all what I have written here. And then for the morphology, you see that the bigger part is 2/3 are heterogeneous patients, but we also have quite a big evidence now on non-heterogeneous, not so much, more on intermediate, but also on homogeneous patients. So this is our lung function data of all patients we have done so far. You can see that the FEV1 from preoperatively goes up in 3 months, 6 months, and it's still up 6 months after 12 months after the operation. So this is not only the very good one. So this is the lung function of all patients we have operated. This is the curve you can see, and you can also see that there is a peak about to 6 months, and then it goes a little bit back already 12 months after the operation. So we have seen usually a benefit that lasts around 3 years, with a maximum of 5 years benefit. So the primary LVRS, as I said, is 723 patients. We have a 30-day mortality of 0.5 and a 90-day mortality of 1.5%. The hospitalization time is 10 days and the chest tube is 6 days in median. So I want to just at the end stretch the theme a little bit and go on the patients that are not eligible for LVRS right away, but we have done a couple of them as well. So the preoperative mortality in high-risk patient, which means less than 20% of EV1 and less than 20% of DLCO, and then a homogeneous distribution, we can see that they have a really high mortality rate. So this is not the patient that we should operate on. So that's from the NET trial, the cohort with the very bad result, right? So we have done a couple of DLCO less than 20% in heterogeneous, which is more easy or better to understand, but also some in homogeneous patient. And we have seen quite a good increase of the FEV1 also in the homogeneous patients. So it is possible in very selected patients. And we have published this as well, the outcome of the lung volume reduction surgery in patients with severely impaired diffusion capacity. We have shown that there is a possibility to do it, but we have to be very careful in selecting this patient. The same is true for LVRS in selected patients with emphysema and pulmonary hypertension. I said earlier on, this is a contraindication, which is not completely true, but we have shown that in the selected patient group, we could find that the preoperative pulmonary hypertension came back. And the reason of this is probably that there is less comprehension of alveolar vessels and left atrium and improved oxygenation and decreased hypoxic vasoconstriction. Another evaluation was the re-LVRS and the reoperated lung volume reduction surgery in patients, in selected patients is also possible. You can see it here in this curve. You can see that it is less, that the benefit is less than in the first intervention, but there is still a benefit that we can show in this population. And then maybe another a little bit specified LVRS patient cohort is LVRs and lung cancer, there is also a possibility to do a lung cancer operation in an LVRS concept. And at the end, maybe also more and more LVRs after valves. So we have shown that lung volume reduction surgery as salvage procedure after previous use of endobronchial valve is possible. And this is our flow chart, what we do when we have done valves and LVRs after valves. So we have seen the LVRS effect compared to BLVR in the Swiss cohort study, and we have seen that the LVRS is doing a little bit better than the valves. And this is the reason why we wanted to do a comparison study, and we started with the Sincere. This is the trial sketch that you can see it here. So there are a couple of institutions participating. There are 3 different hospitals in Switzerland. There is the University of Hospital of Leuven, then the Copenhagen group, and very happy that Austria with the AK Wien is joining us as well. So far we have overall 23 patients treated, 13 of them by LVRS, 10 with valves. And we have screened, just to show you how much work it was at the beginning, at least we have screened you can see we have 11 patients treated, and we had to screen 181 patients to have these 11 patients. So to come to the end, to succeed, it's a teamwork. Patient selections is very important. Start with a heterogeneous emphysema. If you start a program, you have to be in a network with your referring specialists. In summary, we can see that many years after NET, we can conclude that one more time that active treatment for emphysema patient improved dyspnea quality of life. And the choice of the procedure depends on many different aspects, and we try to find out more in a comparison study. More trials are needed, that's for sure. And what is about the homogeneous emphysema inclusion beyond net cranial? We have shown that there is a possibility, but you have to be careful by selecting them. So take home message provides LVRS provides personalized volume reduction, is still underused. I think so. It may be a little bit less in Europe, but in the whole world for sure. The non-heterogeneous are eligible for evaluation, and re-evaluation is feasible. Just to show you that we have this clinical immersion lung volume reduction course in Zurich. We have started this clinical immersion program in 2016 with our partner clinic in Leuven, and we are very happy if there are more people coming to see us in Zurich. Thank you very much for your attention.
Yeah, thank you, Didier, for this detailed perspective on the Zurich data. So Daniela, we're looking forward to hearing your presentation now.
Can you see my slides?
Yes.
Okay, perfect. First, I want to thank you so much that you invited me as pneumologist to give now a talk about the lung volume reduction. I really appreciate this invitation. Now it's a great pleasure for me to talk about the endoscopic lung volume reduction. So now it starts. Yeah, these are my conflict of interests. Now you have heard a lot about the lung volume reduction surgery, and everybody knows that the idea for lung volume reduction is not by us pneumologists. It's indeed by the thoracic surgeons who have already performed the lung volume reduction surgery in the early 1950s. And the thoracic surgeons removed the most emphysematous destroyed lung parenchyma, and thus leading to an improvement of lung function parameter, exercise capacity, and quality of life of the emphysema patients. However, we also know, particularly in the older trials, that the lung volume reduction surgery was also associated with morbidity and mortality. And that is why we searched for alternative treatment approaches with comparable physiological effect, but with less attendant risk in the last 20 years. And so we developed different techniques for the endoscopic lung volume reduction. Today, some of these techniques are performed routinely in the endoscopy units, but of course, we also have forgotten already some of these techniques. And in my talk, I want to explain it a little bit more in detail each technique. But before I discuss these techniques, I want to emphasize again that the patient selection is really, really crucial for a successful endoscopic lung volume reduction. So each patient who wants to undergo an endoscopic lung function test should reveal a very severe hyperinflation with a residual volume of more than 175% or better, more than 200%. Then also each patient has to undergo a high-resolution computer tomography of the scan, and this of the thorax, and this CT scan should confirm the emphysema. It should show us the emphysema distribution, and we should have a look at the fissure integrity. And the fissure integrity is really very important, as the patients with a complete interlobar fissure can be treated by the endoscopic valve treatment. However, the patients with incomplete fissures cannot successfully treated by the endoscopic valve treatment. So we have to discuss other therapeutic options in these patients. But first, I want to talk about the endoscopic valve treatment. This is a procedure that is indeed routinely performed in the endoscopy units. So the valves are one-way valves that are implanted in the most emphysematous-destroyed lung lobe. And these valves allows the air to be expelled during expiration, but not to come in during inspiration, and thus facilitating a lobar atelectasis, and thus leads to a lung volume reduction. I want to present you a short movie about a valve implantation. So the most important thing is that we occlude one lobe completely by the valves. And you can see that I have already implanted here one valve in the segment 8, 9, 10. So I have still to implant one valve in segment 7. You can see now the implantation of the valve in segment 7. You introduce a catheter, and then you can deploy the valve very easily. This technique is a straightforward technique. It lasts about 15 minutes to implant the valves. I prefer to perform this procedure under general anesthesia, but of course it's also possible to perform the valve implantation under local anesthesia. In this slide, you can see the first randomized controlled trials related to the valve treatment. Now let's have a look on the outcome parameters. You can see, yes, it was statistically significant, but of uncertain clinical relevance. But we have learned a lot from these first randomized control trials. We have learned that only the patients with a complete fissure were successfully treated by the valve implantation. And so on the following randomized control trial, only the patient with a complete fissure were enrolled. And we have also learned that we have to occlude one lobe completely by the valves. And then when you look now at the outcome parameters, you can see that the patient really experienced a clinical benefit from the valve treatment. So it's really important that we evaluate the collateral ventilation prior to an endoscopic lung volume reduction. There are two different options how you can evaluate the collateral ventilation. The first option is to perform a CT fissure analysis. And nowadays, there are a lot of different softwares that support us to measure the fissure integrity. And the second option is to perform a Chartis measurement during the bronchoscopy. The Chartis measurement is performed by a Chartis console and a Chartis catheter. So the Chartis catheter is introduced in the lung lobe that you want to treat by the valves. At the distal tip of the Chartis catheter, there's a balloon that can be inflated so that the target lung lobe is completely isolated. And then you can measure the airflow that is coming from the target lobe. If the airflow decreases over the time of the measurement, then you know, okay, the patient has got an absent interlobar collateral ventilation. You can treat this patient successfully by the valves. However, if the lobe, then the patient has got a significant collateral ventilation, and you should not treat this patient by the valves. So when should we perform an additional Chartis measurement? It depends on the site. So when you are looking at the left lung and the major fissure is more than 95%, you can go forward and you can perform a valve implantation. However, if the fissure integrity between 80 and 95%, then you should perform an additional Chartis measurement. With a fissure integrity less than 80%, the patient is not a good candidate for an endoscopic valve treatment. When we are looking at the right side, we should always perform an additional Chartres measurement when the fissure completeness is more than 90%. Less than 90%, the patient will not benefit from the valve treatment. So the absence of interlobar collateral ventilation is really a very important predictor for a successful valve implantation, but there are also other predictors. For example, the heterogeneous emphysema distribution. There's already one randomized controlled trial, the IMPACT trial, that have already demonstrated that also the patients with homogeneous emphysema will benefit from the endoscopic valve treatment. However, we know that patients with a heterogeneous emphysema distribution have got a superior benefit. So last year, Doreen Hartmann published another manuscript. It's all about the target lobe, and she demonstrated that in high emphysematous destruction of the target lobe, in higher air trapping, and a low target lobe perfusion are really important predictors for successful valve treatment. Of course, we know the higher the residual volume, the better is the outcome. The lower the exercise capacity at the baseline, the better the outcome. And we have also seen that the female patients have got a superior benefit, but please don't ask me why. I don't have got an answer to this question. And there are also 2 different trials that have shown that we can also improve the survival of our emphysema patients. So if the patients experienced a complete lobar atelectasis, then the patients have got a survival benefit. But of course, I will also want to talk about the complications. The endoscopic valve treatment is a minimally invasive treatment approach, but of course we can see some complications. And I want to enhance one complication, that is the pneumothorax. If you look at the first randomized controlled trials, the pneumothorax rate was very low, was 4.2% or 4.5%. And then it increased, and now we have got a pneumothorax rate of 30 or 34% in the Liberty trial. Why did the pneumothorax rate increase over the time? Because we started to perform the fissure analysis in 2010 and 2011. So a complete fissure is not only a predictor for a good clinical outcome, the complete fissure is also a predictor for the advent of a pneumothorax. So we can also hypothesize when the patient experiences a pneumothorax due to a very high volume shift, then the patient will also experience a benefit from the valve treatment. And this hypothesis could be confirmed in one retrospective trial that demonstrated that the patients who recovered from the pneumothorax and who have got still a complete lobar atelectasis will have got a substantial benefit from the valve treatment. But of course, a pneumothorax is a complication. We should know how to manage the pneumothorax. So the first step is to insert a chest tube. However, if the pneumothorax is still persistent, then we should remove some valves. And if the pneumothorax is still ongoing, then of course we should also discuss with the thoracic surgeons to perform a video-assisted thoracoscopy and a bluedesis to seal the fistula. Now let's talk about the patients who are at high risk. These are the patients with a low FEV1, low diffusion capacity, patients with a hypercapnia. So let's talk first about the patients with an FEV1 less than 20% of predicted. There are already 2 retrospective trials that demonstrated that these patients can be safely treated by the valves, and also these patients experience a benefit from the valve treatment. The same could be observed in patients with a low diffusion capacity, and the most patients with a low diffusion capacities in these trials had also a very low FEV1. And there are also 2 different trials that demonstrated that also the patients who are hypercapnic can treated safely by the endoscopic valve implantation. And then you can also observe a decrease of the hypercapnia. Of course, I think you know this trial. I want to show it very briefly. This was the first trial that compared the lung volume reduction surgery to the valve treatment. In this trial, 88 patients with severe emphysema were enrolled. They also, all patients had a residual volume of more than 100% of predicted, and they had an absent interlobar collateral ventilation. So 47 patients were treated by the valves, and 41 patients underwent a unilateral video-assisted thoracoscopy. The primary endpoint was a body score after 12 months. So this is now the result. There was no significant difference between the lung volume reduction surgery and the valve treatment. But of course, as pneumologist, I have to mention that these 6 patients who were randomized to the surgical arm refused then the surgical approach, left the study, and they asked for a valve treatment. So because it is a minimally invasive treatment approach. But now I want to talk about the other endoscopic treatment modalities. What can we do in patients who have got an incomplete fissure, who cannot be treated successfully by the valve treatment? First, I want to discuss a little bit with you the bronchoscopic thermal vapor ablation. So in this method, we instillated heated water vapor, and this leads to an inflammatory reaction, so to a shrinkage, and thus to a lower or a lung volume reduction. So in this slide, you can see the published trials related to the bronchoscopic thermal vapor ablation. And now when you look at the numbers of the patients who were treated with BDVA and who are published, is still very low, I think. But if you look at the outcome measurements, you can see that the patient experiencing statistically significant benefit from this treatment. I know that there is one big register trial for the BDVA, so we are still treating the patients with the bronchoscopic thermal vapor ablation, but in my opinion, this should be only performed within clinical trials, because the data are very limited. And we have to wait for the results of the registry trial that is still ongoing. The second option I want to talk about is the coil implantation. So for the coil implantation, we implanted 10 to 12 coils in both upper lobes or in both lower lobes. And these coils led to a compression of the lung parenchyma and to improvement of the lung elastic recoil. And here you can see now all the randomized control trials that were related to the coil treatment. And the biggest trial was the RENEW trial that was published in 2016. You can see that the patients experience a little bit of improvement, but of uncertain clinical relevance, so that actually we don't perform the coil implantation. But afterwards, there was another design of the coils, and these data were published of Tina Controgiani on the ERS 2 years ago as abstract, but you can see directly that these results were not satisfying. There's another design of coils, and they are actually evaluated in a multi-center trial, but this multi-center trial is still ongoing, and we have to wait for the results. I think a more promising technique is maybe the combination of the polymeric lung volume reduction and the valve treatment. So some years ago, we performed the polymeric lung volume reduction for the lung volume reduction itself. So we installated a polymer, and this led also to an inflammatory reaction and to a lower volume reduction. But now we don't perform the polymeric lung volume reduction for the lung volume reduction itself, but for the closure of an incomplete fissure. And afterwards, we can treat the patient with valves. I want to show you the first trial that was published in 2020. By Alvin Ng. He enrolled 14 patients who were CV positive with a fissure integrity of 80 to 95% in this trial. And first he performed the polymer installation, and then he repeated the Chartis measurement. And 9 of these 14 patients indeed was then CV negative, and they had an absent interlobar collateral ventilation. 5 were inconclusive, so they repeated the installation of the polymer. And now let's have a look at the results. These patients who underwent both the polymeric lung volume reduction plus the valve treatment had a very good outcome. They benefited from this combined treatment approach. And if you compare this to the patients who were treated directly by the valves because they had incomplete fissure, they were similar. There was no difference. So in my last slide, I want to give you my take-home messages. So we can perform the valve treatment that is a routinely performed treatment option in our endoscopic units. It's really important to perform a precise patient selection, particularly to exclude insignificant interlobar collateral ventilation. I have shown you the data about the coil implantation, the bronchoscopic thermal ablation. Actually, the BDVA is still available. You can perform it in your patients, but my recommendation recommendation is to perform it within clinical trials. And another approach is a combination of the polymeric lung volume reduction to occlude incomplete features and then to perform the valve treatment. But of course, we need further trials, and there's also one trial ongoing, and I think maybe we will see the results of this trial on the ERS this year. Thank you so much for your attention.
Yeah, thank you, Daniela, for this excellent overview. So we got a couple of questions already. So maybe let's start with a general topic that I think is relevant for any indication for lung volume reduction. Of course, you sometimes have to consider whether to perform a lung volume reduction or whether to perform a transplant. So what are, in your opinion, the lines where the indications separate, or probably where there's an overlapping area or room for sequential treatments?
Yes, maybe I start. Sorry. Yes, for sure there is an overlapping, because it depends a little bit about the emphysema. If there has been a treatment for a pneumothorax in the earlier area or not, and if it's a heterogeneous emphysema, whenever there is a heterogeneous emphysema, we try to do LVRS first as a bridging procedure. There is a little bit of a back side, because if you bridge a patient who is going to 65 years old and maybe he will profit for 3 years and then he is so-called too old for transplantation, this is an issue as well. But whenever possible, we try to do this as a bridging procedure when there is a homogeneous distribution, and we think that the profit will probably not last for longer, not more for a year, or it is very difficult to do, and the comorbidities and the complication rate is too high, then we go for a transplantation directly. So it's not so clearly black and white as it is always in surgery. So or in medicine. It's more a dependent on the individual basis.
Daniela, you have anything to add?
No, I'm fine with this answer.
Okay. So then there are a few technical questions regarding the procedure. So maybe let's start with the valve. Now, David Wallace asking why you still advocate the valve removal if a spontaneous pneumothorax after the valve occurs, and why not leave the valves in situ and treat the air leak from the non-target lobe by VATS?
Thank you so much for this question. I really, really like this idea. So, yeah, the first step in our hospital. So, before I went to Vienna, I worked a long time in Heidelberg, and so the first step and what we have performed is a chest tube insertion, and the second step was a valve removal, because when the lung does not expand, then the pneumothorax is ongoing. You have to have a contact between the two pleures so that the fistula will be sealed. And when we asked the thoracic surgeons to perform a surgical intervention, then they always ask us, did you have already explanted the valves? And we said, no, we did not remove it. Okay, please first go forward and remove the valves. And then we can talk about the video-assisted thoracoscopy when the pneumothorax is still ongoing. But I really like this idea. I think we should discuss it in future if it is possible.
Okay, well, this discussion sounds familiar, and yeah, I can see the point in removing the valves, I have to say. Didier, what's your opinion on that?
Yeah, actually, it's the policy we had up so far most of the time as well, because what we have when we started doing VAS procedures on patients with valves, we always said take out at least one valve first, not all of them, but at least one, so that the lung is a little bit more expanding. Then we tried in another case a little bit later when when there was a pneumothorax occurring only weeks after the implantation of the valves, the pneumologist said to us, we cannot remove the valves anymore because the overinflation will then be too much. So we had to try to do it with the valves in place. And I have to say that there is a possibility to do it with the valves in place, but it depends very much about how big the leak is, where the leak is, and very often you see there a giant bulla occurring around before that this bulla ruptures, and then sometimes we took out the valve during the procedure to be sure that we don't have too much shearing stress on the rest of the lung when we reinflate the lung after the VETS procedure. So we are not completely against, but we are a little bit reluctant doing it straight away.
Yeah, and of course, during the revision surgery, you should achieve the lung volume reduction effect by the resected amount of tissue as well. So Daniela, another question for you. Why is the combination of a polymer together with the valve? Why not just use the polymer alone?
Yeah, so there I think it were 2 trials that was published to the polymeric lung volume reduction, and I want to be very honest. We were not really very satisfied with this approach. So yes, also in these trials, the patient experienced a little bit benefit, but not too much, and we have seen really a lot of complications. The patients experienced a great inflammatory reaction. Some of them had a pneumonia, so that we do not perform a polymeric lung volume reduction itself for the lung volume reduction. So when we want to occlude only the fissures, then the amount of the polymer that we instillate is absolutely less, and so the patients do not have got so many complications afterwards, and that is why we are doing it in this way now.
Okay, so maybe let's go to the surgical part. There was, Daniela, you showed in the trial, the CELEB trial that was performed in unilateral surgery versus in bronchoscopic lung volume reduction. Didier, you showed that you're doing bilateral whenever possible. So maybe can you elaborate a bit on the bilateral versus the staged approach, and what are the advantages of each of them?
I think this is an ongoing debate whether which access is better, if it's unilateral, bilateral. We have the idea, and we showed it in our data, that when we do bilateral at the same time, we have a better result usually than unilateral. But it's not so much better that you can say it's completely wrong if you do unilateral. So this is also also true in different trials that we have seen. I think going for one side and doing the other side on a later date, so we usually don't do it before 6 months after we have done the first side, is also something that we do quite often, especially when we have seen any intraoperative problems during the first side. So we stop and we say, okay, why push too much and having any complication after the operation, instead of doing one side okay and wait till he has recovered and do the second side, which is a possibility. I think books are not closed on this. I don't really have an idea which one is better. I still believe whenever you can do both sides, the benefit at the beginning will be better. But this is just a mechanical thinking, because I think the more you can do and the better you can take out the areas which are overinflated and completely destructed should help more. So if you have done it on one side or on both, usually both sides should be better. So that's what we still go for.
You see any differences in complication rates in uni versus bilateral?
So as I said, we are usually not planning unilateral. We only go for unilateral if we have a problem or if we already have an operation done on one side up front, or if it's severely predominant on one side. So we usually always go for both sides. So that's maybe a bias when I tell you what I think about.
We've heard about surgery as complication management for pneumothorax after valve implantation. What about the other way around? Any experience with valves as a treatment for air leak problems after surgery?
Yes, yes, there are a lot of data that shows us that it is possible to implant the valves in the lung lobe that is in that the fistula is located. And indeed, we have also implanted some valves in one patient for the lung volume reduction. The patient had a pneumothorax, removed the pneumothorax. The patient was very unstable. He could not undergo surgery. And then we implanted the valves in the non-target lobe, where we thought that there's a fistula, and it worked. And afterwards, we could remove the valves again, and the patient had no pneumothorax ongoing. So yes, it is possible. And there are a lot of data about that.
Yeah, I think there is quite a lot of data, not so much about LVRS and emphysema patients, but a lot data about fistula after any other kind of thoracic procedures. We have done a couple of these as well after prolonged fistuling of lung after, for example, operation for infectious disease or whatever. But yeah, we haven't done so many on or not, maybe one or two only on LVRS as I remember.
What about you showed that you're doing the surgeries usually video thoracoscopically. Is there any role for robotic surgery in lung volume reduction surgery?
I think there is, yes, but I also I'm very keen on doing robotics. We did some cases and we didn't really have the benefit. So I didn't really see the benefit of robotics. We tried to find the target area by Firefly, which didn't really work the way we thought it should work. For sure, there is a possibility, a better possibility to compress the lung because you have insufflation of CO2, which we don't usually or we never do when we do VATS procedures, but we usually do when we do RATS procedures. So I think it should work. There is no reason why it shouldn't, but I haven't found myself now a reason why it is better than what we do in VATS, which is something that is just maybe also a bias because we have not the possibility to do everyday RATS procedures. So if we have more often the possibility to have the robot, maybe we would do a couple of more by RATS. I don't know. I don't think it. I cannot say it doesn't work. It does work, and I just have not enough experience to really tell you what you should do.
Well, what about buttressing the staple line? That's something I personally always do. Do you think that's an important issue, or do you think it works without this as well?
Well, we started to, or actually we usually use reinforced buttressed staples right now as well. When I started doing VATS procedures of LVRS, we have not had this, so we didn't use it for the beginning, and then when it started coming in, we thought, oh, we only use it in very destroyed lung. But nowadays, I have to say that we usually use it in any case now.
Yeah. I think also with the robotic technique, there are no real data available so far. It all comes down to personal experience at the moment, probably. There's another question when we're talking about bullectomy or large emphysematous bulla. Of course, surgical resection is a well-established technique. Are there any data, or have you ever tried using valves for bullectomy for
Yeah.
patient with
Yeah,
local
we
bulla?
have performed the valve implantation also on patient with a very big bulla, and sometimes it works, sometimes not. And I think these patients should directly go to the thoracic surgeons only when the patient has got really a lot of comorbidities and or the FEV1 is already less than 20% of predicted. Then you can try to perform a valve treatment. But if the patient is in a good clinical status, go forward and perform a surgery.
Yeah. So there's the issue raised about reimbursement. Of course, this varies greatly from country to country, but maybe can you try to provide an overview for both sides, Daniela? What about the reimbursement situation for bronchoscopic devices, valves or other, and DTA for the surgical perspective, how reimbursement situation is, if you have if you know any data beyond the personal experience.
Yeah, so for the valves, yeah, they are reimbursed, so there's no problem. You can do it routinely in your endoscopy unit. We do not implant any coils anymore because the data were not so good. The BDVA is only performed within clinical trials, but I know that they are fighting now for reimbursement, and for the reimbursement, they are performing now one multi-center trial, and if this trial is successful, then we will also have gotten reimbursement for the BDVA.
Yeah, I'm sure that the valves are reimbursed in Switzerland, and I'm pretty sure that the coils have at least been reimbursed. I don't know if they still are, but for the rest, I just cannot tell. I have no idea.
Okay. Yeah, that's probably really highly individual from country to country. What is not so individual probably is the availability of the different systems. Like, is there a uniform type of valves, for example, available, or are there different manufacturers? Can you elaborate a little bit on that?
Yeah, there are two companies selling the valves. So one is Olympus, and the other company is Pulmonx. The Pulmonx is selling the endobronchial valves. You have seen the movie that was the endobronchial valves, and Olympus has got umbrella-shaped valves. I didn't show it now in the video, but there are two companies selling the valves.
And maybe Didier, do you have any particular recommendations? We talked about the intraoperative staples, the technique, but what about the postoperative drainagement after LVRS? Are there any particularly important recommendations with type of drainages, suction, no suction, digital, non-digital?
Yeah. Thank you. I think during at the end of the operation, very important is to see whether the lung is completely expanding or not. As it was already said by Professor Gumpelmann, that it's very important that the lung has contact to the pleura. So even if there is a small air leak, then it's more quick to solve. But if you have a big air leak during the operation, we try whenever possible to make it as small as possible. And if we still have, after all, we have done quite the big air leak, we usually put two drains. Normally, we only put one drain per side, but usually then we put two drains in. Not only because of the re-expanding lung, but also to prevent the emphysema of the tissue around the incisions. And after the operation, we usually put them on 5 centimeter HO2 suction or without suction at all. Just a Heimlich valve is possible as well. But we always start with 5 centimeter HO2 suction, and usually the day after the operation we change to either no at all or putting in a valve and the bag.
Okay, thanks a lot. There are still several questions remaining. However, unfortunately, we've come to the end of our time today. So I really like to thank the two of you for excellent presentations and providing us a good overview on the topic. I'd like to thank the audience for the active participation, also in the discussion. And at the end, I'd like to draw your attention to the next 2 upcoming webinars. One will already be on Wednesday on biomarkers in non-small cell lung cancer, sponsored by AstraZeneca. And on 19th of February, we are having the next regular ESTS webinar with the topic whether there's a need for gender-based research and treatment in thoracic surgery. And Nuria Novoa, our president-elect, will report on this topic. Thanks a lot again for today, and looking forward to see you again.
Thank you. Bye-bye.
Thank you. Bye.